All right, welcome. Today, we're going to break down one of the most essential skills you'll need as a nurse, applying the nursing process to addiction care. And look, this isn't just for some specialty unit. You are going to see this and use these skills everywhere in your career.
So we'll kick things off by really understanding addiction as a brain disease. From there, we'll follow the exact steps you'll use in practice, walking through assessment, planning, and intervention. And then we'll wrap it all up by putting these skills to the test with a real-world clinical case study.
Okay, let's dive right in. To give truly effective and compassionate care, we first have to get on the same page about what addiction actually is at its core. Right off the bat, it is absolutely crucial to move past any outdated ideas. Addiction is not a moral failing. It's not a lack of willpower. It is a complex, chronic disease of the brain, just like diabetes or heart disease. It's progressive, it involves relapses, and without treatment, it can be fatal. You know, the official term you'll see in the DSM-5, which is kind of the Bible for diagnosing mental health disorders, is substance use disorder. And that term is really important because it gets away from older, stigmatizing language. Instead, it focuses on a specific cluster of symptoms across four main areas: impaired control, social problems, risky use, and the physical effects on the body.
Now, when we talk about those physical effects, there are two huge concepts you'll see all the time: tolerance and withdrawal. Tolerance is when the body adapts, right? It needs more of a substance just to get the same old effect. And withdrawal, that's the body's often painful reaction when the substance is stopped. Both of these are key signs of physical dependence. Okay, so let's move on to the first step in the nursing process and see how this all builds. Assessment. This is where your clinical skills and, just as importantly, your non-judgmental approach are going to shine. A fantastic evidence-based framework you can use in literally any setting, from the ER to a primary care clinic, is called SBIRT. It stands for screening, brief intervention, and referral to treatment. Think of it as a public health approach that helps you spot and help patients early on.
A perfect example of a screening tool is the audit. That's the Alcohol Use Disorders Identification Test. It's a super straightforward 10-question survey. You can see some examples here. A patient can fill it out themselves, or you can do it as an interview. It just helps you quickly figure out a patient's risk by asking about drinking frequency, how much they drink, and any consequences they've had.
Now, the real beauty of this tool is its simplicity. The scoring is easy, and there's a clear trigger. A score of 8 or more for men, or 7 or more for women, tells you, hey, we need to do a more in-depth assessment here. It's your clinical cue to start digging a little deeper. And check this out. This is a crucial assessment skill, being able to tell the difference between intoxication and withdrawal. Just look at how they're basically polar opposites. Opioid intoxication slows everything down. We're talking slow heart rate, low blood pressure, tiny pinpoint pupils. But withdrawal, it's the exact opposite. The body goes into complete overdrive. Spotting these patterns is absolutely critical for patient safety.
All right, so once your assessment is done, you're going to move into the planning phase. This is all about developing a patient-centered care plan. And to do that well, you've got to understand both the legal side of things, how drugs are classified, and the different levels of care that are out there.
As a nurse, you have to be familiar with the DEA's drug schedules. They classify drugs from Schedule 1 down to Schedule V. The rule of thumb is simple. The lower the number, the higher the potential for misuse. So Schedule 1 drugs like heroin have 0 accepted medical use, while Schedule V drugs have the lowest risk.
Planning also means knowing that recovery isn't a single event. It's a long-term journey. Patients often move through what we call a continuum of care. It might start with a medically managed detox, then progress to rehab, and then step down to settings like a halfway house or an intensive outpatient program. And all along the way, hopefully, they're engaging with mutual support groups like AA. And medication is a vital tool in our toolbox. For alcohol use disorder, for example, we have a few really good options. Disulfiram literally makes you sick if you drink alcohol. Naltrexone helps reduce cravings. Acamprosate helps rebalance the brain after withdrawal. Your role in patient education here is huge. Like teaching a patient on disulfiram that they have to avoid even the alcohol in mouthwash is absolutely key to keeping them safe and helping them succeed. So we plan for the long term, but we also have to be ready to intervene in a life-threatening crisis. Your quick, decisive action here can honestly be the difference between life and death. An opioid overdose is one of the most intense emergencies you will ever face. It's the extreme end of opioid intoxication, a life-threatening event caused by severe respiratory depression that can very quickly lead to respiratory arrest. When you suspect an opioid overdose, you're looking for the classic triad:
coma, pinport pupils, and respiratory depression. Your immediate priorities are to support their breathing and administer naloxone, which you probably know as Narcan. And here's the key thing to remember. Narcan wears off, so you have to keep monitoring them closely because they can slip right back into that overdose.
Another really critical emergency is severe alcohol withdrawal. This can escalate into something called alcohol withdrawal delirium, or the DTs. This is not just the shakes. This is a severe, life-threatening condition. Untreated, it has a 20% mortality rate. Your interventions for DTs are just as urgent. You're going to see signs of the body in overdrive, a racing heart, high blood pressure, sweating, along with terrifying hallucinations. The standard of care here is IV benzodiazepines, like Ativan, to manage the symptoms and prevent seizures. Patient safety is everything.
Okay, so we've covered a ton of theory. Now for the fun part. Let's see how this all comes together. We're going to apply the full nursing process to a patient scenario to see how these principles really work in the real world. So let's meet Mr. Stewart. He's 49 years old, and he shows up in the ER terrified that he's had a stroke. His main complaint is that his right hand is totally limp. But as the admitting nurse, your assessment is about to uncover the real story. Your assessment starts to paint a picture. Subjectively, you learn about some major life stressors. Objectively, you notice physical signs and one massive clue. His blood alcohol level is over 3 times the legal limit for driving, yet he's alert and oriented. What does that tell you? It screams high tolerance, which is a hallmark of physical dependence. The diagnosis isn't a stroke at all. It's nerve damage from passing out drunk on his arm. So, based on all of that, you can develop a care plan. The nursing diagnosis is impaired coping. Now, the immediate goal isn't necessarily sobriety tomorrow, it's helping him connect his drinking to the negative consequences, like this trip to the ER. Your interventions are all about breaking through that denial and connecting him with the resources he needs for long-term recovery, like Alcoholics Anonymous. So what's the big takeaway here? As you get ready for your own practice, just remember that addiction is a treatable brain disease. And by consistently applying the nursing process, systematically, without judgment, and with compassion, you have the power to intervene effectively, to foster hope, and to make a real, lasting difference in your patients' recovery journeys.